Hello and welcome to this webinar. I'm Paul Surridge, Chairman of BIHIMA, that's the British Irish Hearing Instrument Manufacturers Association, and it's my pleasure to open the webinar today. But first, a few housekeeping notes. For your information, this webinar is being recorded and will be shared with registered attendees after the event. Second, may I ask you to mute your microphone during the webinar, unless you are speaking. This will minimize any disruption that can be caused when too many people have their microphones on at the same time. I'm sure you've all experienced that. After the presentation today, there will be an opportunity for a Q&A session. If you have any questions, please post them during or after Professor Munro's presentation on the chat box so they can be monitored and answered. My colleague Liz Pusey will be our facilitator for the Q&A session later. So why this webinar? BIHIMA had discussions with Professor Munro after the publication of the joint position statement he wrote about adult onset hearing loss and dementia, alongside colleagues from the BSHAA, that's the British Society of Audiology, the BAA, the British Academy of Audiology, and BSHAA, British Society of Hearing Aid Audiologists. For quite some time, media reports and social media have elevated the link between hearing loss and dementia, and it was thought appropriate to put this whole subject in context to ensure accurate and not misleading information was available to the public through the media generally and third-party sources. I'm hopeful today's webinar will be a positive contribution to that debate. In addition to Professor Munro's presentation today, we have representatives from the BAA, the BSA, and the BSHAA on the panel. Perhaps I could ask them to introduce themselves individually, starting with Siobhan Brennan from the BSA. Are you there, Siobhan?
If for any reason she's not or she's not able to speak, then we can move through. Hopefully she can jump in if she's maybe a few minutes late.
So we have Siobhan Brennan from the BSA, we have Lynn Wetherill from BSHAA, and Claire Benton from BAA. So thank you all. I would now like to introduce and welcome our presenter today, Professor Kevin Munro, who I'm sure will be known to many. Kevin, may I ask you to introduce yourself and deliver your presentation?
Thank you very much, Paul. Thank you, Liz. Thanks for the invite. So I'm Kevin Munro. I'm a professor of audiology and a clinical scientist in Manchester. And I'm pleased to receive the invite today. I have prepared some slides. The guidance I was given was to have some slides that might take about 30 minutes, and then that should leave plenty of time for any discussion and questions. And Liz and others, I think, are going to be keeping an eye on the chat. And we'll be able to field the questions when the time comes along. So thank you, good morning, and thanks for joining us.
Thank you, Kevin. Sorry to interrupt you. I've just had a couple of people in the chat say that they can't see the presentation. I know that others have been able to say they can see it. I don't know if it's an individual settings thing, because I know you shared it and I can see it without any issue. I will keep an eye on it, because I think you've got it shared for everybody, but just, yeah, a lot of people are also saying they can see it. Yeah, so, okay, sorry, I'll let you continue.
Yeah, no problem. Technology. I think if some people can see and hear me, if there's a problem, it must be an individual end. But at least if anything goes wrong, it's being recorded, so everyone will get access to it in due course. I noticed the people who originally said they couldn't see it, went out and came back in and were able to see it. So I don't know if that's something it's worth trying. So I was just about to say that sometimes in life we're faced with uncertainties. Sometimes it's in our career, sometimes it's in home life. So does hearing loss cause dementia? What should we say to a patient if we are a hearing professional and we're meeting with them one-to-one? Will hearing aids reduce the risk of dementia? What should we say to a patient when we have them in the clinic and we're a hearing professional? So the relationship between hearing loss and dementia is complex, and there are currently a number of uncertainties, and it's particularly tricky because dementia is such an emotive word to many people. When you mention it, it's like using the word cancer. It stops people in their tracks. And this is because dementia can have and we probably all know this from personal experience with our own families, kind of a devastating impact on the individual. It can have a devastating impact on family and carers. And also it can have a devastating impact on our health and care system. So here's an example. 5 years ago, just now, we were 1 month or thereabouts into the first pandemic lockdown. And there were many uncertainties. And one of the things we were frequently told by government was we're following the science. So good that they put the emphasis on the evidence. But when you say you're following the science, it sounds like there's already a well-defined road to follow. But actually, sometimes the road is still under construction and we don't know the answer. And if you remember back to the anxieties we had 5 years ago, when I think one of the first things we were told was to wash our hands while we're singing Happy Birthday twice. And then there was uncertainty, for example, about should we wear face masks or shouldn't we wear face masks. So there are uncertainties in everyday life and there are uncertainties in clinical practice. So there's currently a lack of an evidence-based clinical guideline on the assessment and management of people with hearing loss and dementia. And that's a potential barrier for us. So just to set the scene, let me just introduce 3 different publications. And here's the very first one. This is a publication from the World Health Organization. I think it's actually currently under review right now, where they give recommendations on reducing the risk of cognitive decline and dementia. With reference to our component, which of course is only a very small part of the overall topic and area of dementia, they said that they couldn't make a recommendation on hearing loss because of lack of evidence. Here's another publication. This one is more recent. This one was published just in January this year. So this second publication is an umbrella review of reviews. So a review collates all the studies on a topic. And an umbrella review is a review of all the reviews that have previously been published on the topic, at least at that time when it was being prepared. And it aims to give a sort of bird's eye view of the landscape. So it will miss any very recent studies that didn't make it into a review because they were so recent. But this one in January talks about the known benefits of using hearing aids in adults, but it says the review of previous reviews found there was a clear lack of high quality evidence and limited use of robust study design to support the benefits of hearing aids on outcomes such as cognition. At the current time, the Cochrane review, we have a Cochrane review that was led by Mel Ferguson when she was in Nottingham, looking at the effectiveness or the benefit of hearing aids for adults with mild to moderate hearing loss. And the original one, the one that we currently use, does not look at cognitive outcomes. But my understanding is that's been revised. They have looked at cognitive outcomes. So shortly, hopefully, we're going to see what Cochrane tell us and what we can use for guidance. And then let me come to this third one, which probably has had the highest profile. So this comes from the Lancet, originally in 2017, and it's been revised twice, the most recent one last summer. So the Lancet, as most or everyone on the call will know, is a very high quality medical journal. So people tend to sit up and take notice of it. The Dementia Commission represents a huge amount of work and it's well cited. And the hearing loss component, as I mentioned earlier, is just one actually relatively small part of the overall work. But if you look at the comments from the Lancet Commission, you'll see that these look to be rather confident claims and don't seem to be consistent with the 2 previous studies. So these are direct quotes from the article. One is, evidence is increasing and is now stronger than before that tackling hearing loss reduces the risk of developing dementia. The evidence that treating hearing loss decreases risk of dementia is now stronger. So you could be forgiven for thinking that the evidence is very clear and there are no uncertainties. To my mind, and to a great many people's mind working within audiology and hearing care, the evidence is not clear and there are still many uncertainties. When there's a newspaper headline or even a peer-reviewed scientific article, if we're not told about the quality of the evidence or about the uncertainties, all we get is a headline message and we assume that the evidence is strong, right? Because we have no choice and we have no reason to doubt it because no one's pointed that out to us. But actually, histories repeat with examples where there's been confident claims that have been made and then they've been contradicted by reality and the conclusions have had to change. And I want to give you this one, which is not to do with hearing, but this is newspaper headline from 2002, when Tony Blair and the government took us to war with Iraq because they told us there were weapons of mass destruction that could be launched within 45 minutes, and Iraq was building nuclear weapons. Actually, it turns out that the evidence wasn't conclusive and there were lots of uncertainties, and it was only after this event happened that we've come to realize about the uncertainties, and people will dispute it, but for many this was like a rather major issue, that the UK was taken to war on information that was known to be uncertain. So that's a rather dramatic one. But there's things uncertain about our area, hearing loss and dementia. And hearing loss and dementia is not the only thing where there's uncertainty. Recreational noise exposure would be another one. We know that excessive exposure to high levels of noise can damage hearing, and we've seen that over many years in occupations. And now there's concerns that young people are listening to high levels of music, but there's uncertainty. There's certainly a hazard there, but we don't know if they're listening to it frequently enough at a high enough level on such a regular basis that it is going to damage their hearing. So the hearing loss and dementia one is just one example where we have to find a way of dealing with uncertainties. So Piers Dawes, a former colleague of mine in Manchester, was kind enough to invite me to be a co-author on this Points of View article that was published last year. And this was published in an academic journal called Ear and Hearing. And the aim of a Points of View article is to stimulate interest and discussion. And that seems to have worked, because there's this thing called the Reader's Award, which I think is simply a reflection on the number of times that someone has looked at your article. So we won this award because lots of people were interested in the topic and looking at the article. You shouldn't be misled to thinking that means they all agree with the quality and every single aspect of the article, but it's certainly topical and of much interest. So these articles are typically giving an opinion or a fresh point of view. And our plan then had been that we wanted to, talk about the quality of the evidence to address any uncertainties, because there's lots of terms that we've started to use within audiology and hearing care that we haven't used before, and there's always a danger that these are going to be misunderstood or misinterpreted. So that was the purpose of that article. It's free, you can download it if you haven't already done so. And we decided that busy hearing professionals, like some of you people, might not have the time to pore over this academic type of article. So we made it more accessible in these kind of short magazine type articles, coffee break reads. And some of them we initiated, and other ones, the bottom left one from USA, we were invited to provide answers to questions. And the two on the right hand side, I think one I was invited to write an article, and then on the second one I was given questions and asked to provide answers. But actually this is maybe an opportunity for me to underline the fact that the work that we're talking about today is aimed at autonomous hearing professionals who work with individual clients. It's not aimed at policymakers or population level. I think that there are important messages to be shared there, but they might be told in a different way. So the next few slides will run through the sort of topics that were discussed in all of these articles, just to give you a flavour. Oh, first one, and we're going to start this slide from the left-hand side, is looking at the possible mechanisms that link hearing loss with dementia. So we know there's a link, we know there's an association, but we want to understand the mechanism, the nature of that link. So it's often hypothesized that hearing loss might be responsible for causing dementia, meaning that somehow hearing loss changes the brain, either because we've got this impoverished signal going and so it's distorted, or the auditory system is, and ultimately the brain is deprived, or at the opposite end of the continuum, that the brain is having to work harder to extract this poorer quality information that's coming in, and that these somehow lead to permanent changes in our brain that cause cognitive decline and dementia. These would be direct causes. There are also indirect ones, perhaps the social isolation that comes from hearing loss, or mental health issues indirectly are responsible for cognitive decline. So this is an intriguing one, because if hearing loss causes cognitive decline, there is a potential that using hearing aids to restore auditory function, not to normal, we all know that, those of us that have hearing loss and wear hearing aids, it potentially could reduce the risk. The middle figure is saying, well, maybe it's the dementia pathology that somehow causes the hearing loss. I think this is what people would refer to as, if my understanding is correct, reverse causation. That's something about the change in the brain because of the cognitive pathology that affects hearing. And then the one on the far right is saying, actually, because multiple things are associated with dementia, if you look at senses, it isn't just our hearing, ears, eyes, touch, smell, taste, are all linked with dementia. So maybe there's just something in common. We need to find an explanation that can justify why all of these different things have a link. Are we saying there's a separate, they're all separate? Hearing loss is separate and causes dementia, visual problems separate causes dementia, or might it be a common cause? And common causes might be things like vascular changes in the brain, the sort of thing that happens as we get older, some neurodegenerative changes. And it's possible that even if it's a common cause, not all of these symptoms will occur at once. Maybe hearing loss will occur before cognitive decline without it being hearing loss that causes it. It could be because maybe the multiple neural pathways for cognition are a lot more robust than the auditory system, or maybe auditory traits are more sensitive. In any case, there's just been what's called the James Underlines Priority Setting Partnership on hearing loss and dementia, two very common chronic conditions that often occur together. And that's just been completed. So we'll shortly be seeing what are the research priorities of clinicians and people with lived experience. And at least some of the top questions, I'm sure, are going to be related to helping us understand this relationship. And just the final point I should say before moving on is, I've explained them as if they're all separate mechanisms, but maybe there's an element of each, and it's not just one of them that would explain the relationship. And there's a reference there if you want to follow up, which is now 10 years old, but I think gives a very good explanation of the possible mechanisms and why it may be multiple mechanisms that explains the relationship. Another thing that we want to talk about in these articles was about the quality of evidence. So this is not really specific to hearing loss in dementia. We're just using that as a vehicle. We're talking about the quality of research that provides the knowledge that helps influence practice. So sometimes the evidence comes from observational studies. That's where there's been no attempt to randomize people and say, you're going to get a hearing aid and you're not, and we're going to see which group ends up with more cognitive decline or dementia. It simply tracks people, some of whom have chosen to obtain and use hearing aids, and some who haven't. And that's one of the major limitations of observational studies, that there are clearly differences between people who choose to go down one route and people who don't, and that might be difference in educational level, for example, differences in lifestyle. So that's one of the fundamental weaknesses if we rely solely on observational studies. Now, more recently, there's been ways to tackle, or at least try to reduce, some of these biases. And there's this thing called a target trial emulation, where you say, I'm going to plan a study as if it was one of these gold standard randomized controlled trials. And I'm going to match the people in the both groups, and I'm going to do as many things as I can as possible to avoid errors in the methods and the analysis, which is good. And there has been one on this particular topic, so you can go online and search for this article from last year that took observational data, did the analysis and the design following a target trial emulation, the way they'd want to do it if it was a randomized controlled trial. The key point to remember is, of course, the participants still weren't randomized, so there's still something fundamentally different between the two groups of people. So although it's better and it can be supportive, it doesn't solve all of the problems. So that takes us to randomized controlled trials that are considered the gold standard, particularly if they're blinded, where a group of people who are willing to be part of the study, are willing to have any of the treatments, are randomized. So some get, in our case, hearing aids, and some don't. And they're generally considered the most robust ones. But we do have to be careful. How much importance should you attach if there's only one randomized control trial in the area? How much importance should you attach if the effect size is relatively small? So you have an average effect size, but you or me might have an individual patient sitting in front of us. And I think it was Winston Churchill that said in the 1940s, democracy is the worst form of government, except for all the other ones that have been tried. And I think you could probably say something similar about randomized controlled trial. It's the worst form of design. It's better than all the other ones that's been tried. So that's why we normally need a collection of good quality randomized controlled trials. And people will do these things called systematic reviews, so they can look for the overall pattern of results, and they often put all the findings together and do what's called a meta-analysis to say, when we join all the studies together, this is what the conclusion is. And if multiple randomized controlled trials are showing the same effect, then they're more likely to be correct. There's also, it's not always possible to do a randomized controlled trial for ethical reasons. So there are people working on different approaches that can help answer the questions that you and I are interested in today. So alternative methods, one of them, for example, a genetic one, is Mendelian randomization. And there are other approaches like that that might just be able to help shed light on the nature of the relationship. But just to expand a bit on the issue with randomized controlled trials, there are health conditions where there's been lots of randomized controlled trials. So unlike hearing loss and dementia, where it feels like we're just at the start of the journey, there are other health conditions. And here are three medicines. These are antipsychotics. And a head-to-head study was set up between medicine A and medicine B. And medicine A was shown to be more effective than medicine B. So medicine A won that comparison. There was a separate randomized controlled trial that compared medicine B with medicine C, and medicine B won that head-to-head comparison. And then there was a third randomized controlled trial that compared the poorest performing medicine, medicine C, with medicine A. And this time, unexpectedly, medicine C was shown to be the better one. Excuse me a minute, somebody's just trying to contact me. Okay, Liz, so there are people from BAA, Claire and Victoria, saying they've been waiting for 30 minutes to get into the so I don't know if there's multiple links, Liz, but can I just leave that with you and I'll carry on talking.
Yeah, absolutely.
Thank you. So there's an example where if randomized controlled trials are the gold standard, how can there be different answers? And it must mean even some randomized controlled trials have hidden biases, and that's another reason for being measured in our approach when we're commenting on the evidence on the topic that we are particularly interested in today. So last summer, I forget exactly when, August, I think, just after the Lancet Commission had been updated, it was published, I think, July. I was kindly invited by the team, ENT and Audiology News, to write a commentary on the hearing loss component. And as I've mentioned earlier, this is a very long, lengthy document, and there are something like 2 pages on the area, which of course is of primary interest to us working in the area of hearing science or audiology. Anyway, they were kind enough to ask me to write a commentary, and I did that. And one of the approaches I did when I was going through it was to explain some of the points that we've just been discussing. So to look at the quality of evidence. Is it a relationship? Can we say one causes the other? We can look at what are the evidence for the benefit of interventions. In epidemiological studies, we use the term risk to mean there's a predictor, there's an association, but that's not the way it's used. When you and I use risk in everyday life, we might say, if this rain doesn't stop, there's a risk we're going to have flooding. And we mean the heavy rain will cause flooding if it's going to carry on. That's not what risk means in epidemiological terms. It means there's a relationship there, there's a predictor, not necessarily that it's a cause. Trying to explain the difference between associations and causation. And then we have risk factors, modifiable risk factors, things that could reduce the risk and remove the hazard, and things that in theory might be able to do it, and they are potentially modifiable risk factors. So some things will be shown to reduce, and they're modifiable risk factors, but some in theory may have the potential, so they're potentially modifiable risk factors, and hearing aids fall into that category. They have the potential because we don't know for sure yet. And then there's things like population attributable fraction and personal risk, and probably these were terms that the majority of us had not been familiar with until this topic gets all the importance that it does. So that was published. Actually, it's attracted lots of attention, and many of the work we've done has been reproduced by different organisations in different countries. So clearly, it's an issue that's important to a great many people across the world, not just in the UK. So on the back of the previous work, Richard Windle and BSA Council approached me to ask if I would lead a group that would produce guidance to help people who are working as independent hearing professionals and are faced on a daily basis with individual people with hearing loss in front of them. So the motivation for this was there are current uncertainties, that there are misunderstandings and the potential for misunderstandings and misrepresentation, and lack of an existing document for hearing professionals. So the BSA produce a whole range of articles in different formats, from recommended procedure, which might be, most people here are probably familiar with the recommended procedure for pure tone audiometry, for example. Practice guidance is broader than just an individual procedure, and a position statement explains the position of the BSA on matters that are current or topical or controversial. It usually undergoes the same process as any other article, but in an accelerated way, because we can't wait a year or two for the information to be put together. It does mean that these more rapid documents define an interim position, which may well change because we may decide actually there's things we should have added or we could have said differently, or actually there's now new knowledge that we can use. So we would expect it to change. So it's a transparent mechanism. The process for all these documents, how you go about doing one, was laid down by the Professional Practice Committee about 18 months, 2 years ago, long before this topic became of interest for producing a document. And great that there was consultation and agreement across 3 boards or councils, BSA, BAA and BSHAA. That demonstrates to the outside world that we do know how to amplify things that are important to all of us, and that we just don't have nothing but fundamental disagreements. And also there was the input from the BSA Professional Practice Committee, and I think we had 12 or 13 stakeholders who helped author the document. These included people across the UK. We had some international experts, and very importantly, people with lived experience of hearing loss. So it's not just the views of people like me, it's a collective view. So as I say, it's a living document. It will likely change over time, partly because there may be other points we want to add, or new knowledge will come along. Why is the content relevant to clinical practice? This might feel like stating the obvious, but it's there to promote continuous improvement and keep all of our knowledge up to date. Sorry, I'm just noticing people who had difficulty getting in have now got in, so that's well done everyone for persevering. Gold star there. Another reason for it being relevant is it ensures the practice is things we do are supported by evidence-based critical thinking, and it provides guidance to justify the decisions and actions we take, because we are independent, most of us on the call hearing health professionals, and we have to be able to justify the things that we do in our clinical practice. So it's there to support us while we're working independently and making decisions. So I should just thank everyone who was involved. It was a huge commitment. You know, everyone is volunteering to do it on top of the normal day job that everyone has, and it took a considerable amount of time and head scratching to put this document together. It's been reproduced by some other organizations across the world. The key points that we kept in mind when we were preparing this document was, what are the principles when you're trying to communicate something where there's uncertainty? Do you just bury your head in the sand and ignore it and pretend it's not there? Or how much importance do you attach, and how do you explain this to someone? So these are the sorts of points. If you look at principles when you're trying to communicate, particularly scientific uncertainty, you want to inform in an accessible and usable manner. You want to give a balanced account, so you want to be upfront about any uncertainties. You should acknowledge limitations in evidence, and it's also an opportunity, at least in our case, to preempt any pre-existing misunderstandings. And a number of organisations have asked if we could use our materials, not all in the UK, so in Canada, USA, for example. So in January, we published a letter to the editor in the International Journal of Audiology, explaining the practice guidance, showing people where the link is, and explaining some of the key points about it. So now I just want to explain some of the key points that's in the document and available for you to download free of charge. And we're currently still on the very first version because it only came out in November, but chances are it's going to be revised and updated in due course. So let's go through some examples. One of them is this thing called the population attributable fraction. And that's what's been used to justify this statement that hearing loss is the biggest risk factor for dementia. And people may be very familiar with this kind of river flow chart as you pass through life, and there's numbers against it about the risk factor. And it's used in epidemiological work to estimate, if we use our example, how many dementia cases could be reduced if hearing loss causes dementia, and there's an unknown there, and if hearing loss completely remove the problems caused by hearing loss. And we know that's not correct, right? Not everyone comes forward for intervention right now. That might be a point we come back to. And we also know that even if you have a hearing aid or a cochlear implant, great as they are, things don't return completely to normal. So the way it's calculated is, well, first of all, there's the assumption that hearing loss causes dementia. There's an assumption that all hearing loss in the world can be totally corrected. And then there are numbers that have to go in to the equation. One of them is how many people have hearing loss. And it's very critical on these numbers. In the very first issue of the Lancet Dementia Commission, the prevalence of hearing loss that was used in the calculation was something like 31 or 32%. In the most recent one, it's shot up to something like 59%. And that, I think, is because In the previous ones, prevalence of hearing loss was typically based on people who had a hearing loss greater than 25 dBHL. In the current one, they've taken 20 dB, and actually huge numbers, like 30% of people are in that 20 to 25 dB. So a small tweak of a number can make a very big difference. The other thing is, in addition to how many people have the condition, is looking at the relative risk. How likely is it, if you have hearing loss, that you're going to get dementia? And in the original Lancet Commission, it was 1.9 for hearing. I'll explain more about that in just a minute. It's been revised out and it's now 1.4. So that actually significantly reduces the risk. But because the Lancet Commission has now used hearing loss of 20 dB, and once you get to an older age, that's almost everyone, right? It puts the number up. So the point I want to make is it can be useful, but it's hypothetical and it's meaningless if you've got an individual patient in front of you, because it's not the risk to them as an individual. I also wanted to point out that lots of people have tried calculating these paths, as they're called, and you get different numbers every time. This graph is showing bar charts for different regions in Italy, and it's showing you when the calculation was done in Italy, depending on where you live, the number's going to vary. So I'll put an asterisk to say, look, there's some regions of Italy where it's up at about 45%, and then other areas it's down about 30%. Don't worry so much about the different colours in the column, but that's taking the different risk factors. And if you go back and look at this later, you can, if you want, go across and see what are the ones that are varying the most that accounts for that difference. And I think you'll see there are often things like air pollution, diabetes, physical inactivity, for example. But the other thing to comment is it varies from one country to the other. So there's been some studies done in Canada showing variations, and also if you take compared to Australia, India has less obesity, so that's a lower risk, but people in India in general have lower education, and that increases the risk. So you have to be very careful how you work with these things. In any case, they're not relevant to the individual. So I just wanted to take a slight deviation and tell you about and share with you a newspaper article that appeared this week that some of you might have seen. So early this month, about 2 weeks ago, I was on a Radio 4 programme with others called Inside Health, where we're answering listeners' questions on hearing loss and hearing aids. We'd had a half-hour programme a few weeks before, and people had written in, and the team at Inside Health said, well, there's so much interest in hearing loss, which in some ways is great for us to hear. Can you answer these questions? Anyway, a journalist contacted me afterwards, I think maybe the same day or the next day, to say, I'd really like to discuss some of the points you raised. Things, for example, like how do you encourage people to take an interest in their hearing and have regular hearing tests? And also, the presenter, James, had asked me about my own hearing loss. So just to clarify, so I have a congenital dead ear on one side, and in more recent years, I've had to use a hearing aid on my good ear. So we had a discussion on last Monday, I think it was, about 50-minute discussion remotely. I was sitting in this room here. Dementia wasn't really mentioned, other than in passing. When the journalist mentioned it in passing, I just paused and said, of course, we don't know which one causes which. Anyway, so the article came out at the start of this week, and here's the article. And if you look at the headline, you'd be forgiven for thinking that, and also because my photograph is there, that I'm warning people about this link. And I've just pulled out a couple of the quotes from the article. The one on the left, hearing loss is to blame for 1/3 of dementia cases in older people. And then the quote on the right, hearing aids have been shown to reduce the risk of dementia to the level of a person with normal hearing. And that's a quote that comes from the Alzheimer's Society. Now, given what we've already said about the concern that people have about dementia and the emotive term, you wouldn't be surprised if people reading this got a bit concerned. And on Tuesday this week, an elderly man who's a hearing aid user contacted me to say he was concerned about this message that I was saying. So they're associating it with me, that hearing loss causes dementia, and it was quite a blow. And what's other people going to think that have hearing aids. Between me being interviewed by the journalist and this article appearing, an academic article appeared using these paths that we've just been talking about. And that's what had been a press release and the journalist had seen, and that had influenced the content of this article. Also, if you go to the Alzheimer's website, and I did this in November last year, and I wrote what I hope was a polite email to the Alzheimer's Society questioning this comment on the website. And I looked again yesterday and today, and it's still there. It says, to reduce the risk of dementia, it's important to get your hearing tested. The use of hearing aids has been shown to reduce the risk of dementia to the level of a person with normal hearing. Actually, if I remember correctly, the Alzheimer's Society got back to me. It was a volunteer saying, I'm going to have to take it up with someone else. There's been a few people that have written to, and I haven't always been able to continually follow people up because I have a day job too. But just wondering where that might come from. There was an article that was published in The Lancet in 2023 that's now been retracted. It actually took a considerable effort from a researcher in Edinburgh who spotted there was something not right with it, who originally thought he wasn't doing something right, and then realised, no, it isn't me, the authors haven't got this right. And he went repeatedly to the authors and repeatedly to The Lancet, and it took considerable time, a lot of prodding. So although we think very highly of The Lancet, the Lancet is run by humans like you and me, and we're all fallible. So The Lancet is not always correct, and it's not always quick to retract incorrect statements. What the original article said was that when we look at people who have a hearing with normal hearing or a hearing loss, some of whom choose to wear hearing aids, and we get the data from this thing called the UK Biobank, the people who are using hearing aids, I'll just read it for you. Hearing aid use is associated with risk of dementia of a similar level to that of people without hearing loss. That may well be where the Alzheimer's Society has got it. Turns out the research team got their groups muddled up, and it's the people who use hearing aids who are at the higher risk and more likely to get dementia. So the complete opposite of what was published. Of course, the retraction didn't get the same publicity as all the previous one. And in some ways it makes sense because people who wear hearing aids have more hearing loss. We know that the more hearing loss is associated with a higher link with dementia. So if you've got more hearing loss, you're more likely to use a hearing aid and you have a higher risk of dementia. It's not necessarily that it's the hearing aid that is causing dementia in the correct interpretation or the other way around. So we have to be so careful about how we phrase these things. Individual risk. So this, I think, is important when you've got an individual sitting in front of you. And I'm going to talk about this thing called a relative risk. And one is you have the same risk as people who don't have this potential risk factor. If the number is higher than 1, that means you have a higher risk of dementia. And just to put into perspective, the relative risk for smoking causing small cell carcinoma of the lung is more than 20. Right, so that's a very high number. Although that doesn't mean everyone who smokes gets cancer. I think something like 1 in 6 people who smoke get cancer. And when people calculate these things, you do have to be careful because there is a tendency that people group everything together. So they assume all hearing loss is the same or all dementia is the same. But actually, there are different causes of dementia. Alzheimer being the most common one for about 2/3 of people. There's vascular dementia accounts for, to the best of my knowledge, about 15% of people. And actually, I've given a reference there for a study that showed that hearing loss was a higher risk for Alzheimer's, but not for vascular dementia. I'm going to have to go back and look at it more closely. It might be that there weren't that many studies for the vascular one because it's less common, so the confidence intervals are wider. But let's look at this, the individual risk factor, and I've listed them here. This comes from the Lancet Commission, the one that was published last year, and I've ranked them not because it's a competition, but just for you to see where hearing loss fits in amongst it at the individual level. You'll see top of the list is depression, there's traumatic brain injury, diabetes, less education. I think the thinking there is if you have less cognitive reserve, if something goes wrong with cognition, you've got less to fall back in, so you're more likely to fall over into the category of dementia. Social isolation, untreated hearing loss, untreated vision loss, and there's hearing loss. In that ranking, it's 7. Different people do their rankings and it'll be in different places, but you'll see it's sort of in the middle. And it's very similar to the ones below it: obesity, high cholesterol, smoking, excessive alcohol consumption, hypertension. They're all relatively similar. So at the individual level, if someone's asking you about this, it's not this headline catching thing about the population attributable fraction. It would be the relative risk. It would be these ones here that you use, and certainly hearing loss is there. But you'll see it's probably no more important or no less important than a whole range of other factors. So within the position statement and the practice guide, we have some suggested statements, the positive things to say about adult onset hearing loss, that it reduces, well, not positive, but the factual ones, that it reduces your ability to communicate with ease. It means your brain may need to work harder to understand what's been said, particularly in background noise. It can limit your social interactions, etc. Hearing aids make spoken communication easier, will improve your quality of life, helps keep you socially engaged, which is a very important point. This will help you live better, makes listening less effortful. And the guidance is to say, don't keep putting dementia at the very front and using terms like that, because it can be very frightening, and we have to have a balanced approach of how we're going to discuss such things. And there are a number of take-home messages in the document, and here are just 2 of them that I wanted to share today. Hearing better can help you to live better. However, it is misleading to imply there is evidence that hearing loss causes dementia and that treating hearing loss will reduce the risk of dementia. So we're not saying these things may not be true. We're saying there's not good quality evidence from multiple sources to justify putting it front and foremost. And although hearing loss is associated with increased risk of dementia at a population level, it's not the leading risk factor for dementia at the individual level. And then we have some examples of frequently asked questions to give you some guidance on how you might address them. So here's one. So wearing hearing aids won't help my brain. So we've said, well, listening and trying to communicate with others when you have a hearing loss can be a challenge. If hearing aids help you to hear more easily, this means your brain probably doesn't have to work so hard. This could free up your brain to do other things, and that could be good for people with and without cognitive decline, or people with and without dementia. I think that's a factually correct statement. So we're not backing away from the association between hearing loss and dementia, but because of the uncertainties, we're trying to find the appropriate words without upsetting and scaremongering. And just want to finish now, before we go into questions, with really a few of my own thoughts as we come towards the end of the presentation. So what is the right choice of words to use in the clinic, or if you're talking to someone? So I often think of this if I'm talking with my elderly father who has a severe hearing loss and uses 2 hearing aids. So I would usually start by promoting the positive message. And I have a variety of these mantras, but this is one I use. I will say, well, hearing better is going to help you to grow better. If it's for a young person, it's going to help you to live better, usually if it's a working age person, and it's going to help you to age better. And I think that's a simple, powerful, and an accurate message. And actually, if we all spoke with a common voice when we're lobbying and trying to get the attention of the policymakers and things, that could be a very powerful message. I emphasize the proven benefits of hearing aids, and I also make clear that the benefits extend beyond the immediate things about our hearing and making it easier to communicate, but to discuss the wider aspects related to health and well-being. I think, you know, the importance of staying connected and not being isolated is so important for people's health, and hearing aids certainly have the potential to do that. And that would be the things that I would sell. What about, though, when we come more specifically to things like dementia? Well, I would temper what I say based on the strength of the evidence and what I currently know. And I might just make a comment here. We used to, I guess, assume that hearing loss occurred in isolation. We now know that's not the case. Hearing loss is associated with a number of health conditions. Dementia is one of them. Another example I'll give you, one of my colleagues has been working in this area, is Parkinson's disease. And actually the most recent study that I saw on that suggested that the relative risk to the individual, if they have a hearing loss, is higher for Parkinson's disease than dementia. They won't be the only ones, but I'm trying to make the point, you have to be so careful because of all these associations. So I would, I may talk about dementia, but it would come well down my list. If at all, it may not be appropriate, right? As a health professional, you will know that the word that you choose might differ depending on the nature of the person you're with. I tend to avoid, because of the emotive nature, using words like dementia and risk, because lay public think risk means I'm going to get it. And I'm more likely to talk about cognitive decline and the links or the associations. So depending on the individual that I have in front of me, or as my father, I might be saying things like, well, hearing loss is important, but it's similar to other things like high cholesterol or diabetes or increased blood pressure or physical exercise. And then I might say, well, for some people who are at high risk of cognitive decline, it's possible that hearing aids may slow that process, but I can't be sure. That would be the way that I currently phrase it, and I'd be very interested to hear what other people say. And I may be wrong, but I think these sorts of comments are similar to what I hear the research team for the ACHIEVE study. That's the one where there was a randomized controlled trial. Some people got hearing aids and some didn't, and look at cognitive decline over time. I think these are the sorts of ways that they approach it when they're in a clinical situation on a one-to-one basis. For all I know, there might be somebody from ACHIEVE on the study, and they can comment or correct me if I'm wrong. So in closing, what would I say? Well, we've got the position statement and the practice guidance. We're each accountable for our own practice, and we should be able to justify our decisions. So there's a document to guide you. It's a guide to help us work within our scope of practice, and it's a living document, and it will almost definitely be modified and change over time. I can tell you that I think we're consistent with the World Health Organization recommendations, where they don't highlight anything for hearing loss right now. Although, as I mentioned at the beginning, it is being reviewed, and we wait eagerly to hear about the updated Cochrane review. But been very pleased that our UK document has received international interest and stimulated lots of discussion. I think this topic provokes discussion of wider issues. I think probably as a profession we've been a bit rubbishy, and we need to get better at understanding what motivates health behaviour and do a better job at addressing this at all levels, not necessarily just focusing on this one aspect of dementia and potentially frightening people into doing something. So we need to understand what motivates health behaviours. What can we do so people from a young age think it's quite normal to take an interest in their hearing and to be testing it from time to time and having earlier intervention. I think some of the recent discussions on over-the-counter devices and AirPods and things might help break down some of these barriers. But I do think we need to address it on all levels within our area of audiology and hearing, not just on dementia. And I think the final point is, I think there has been a focus so far on the nature of the relationship between hearing loss and dementia. And I think that's possibly been at the detriment of other research on hearing loss and dementia. Like, how should we assess one? How do we manage people that especially older people that are going to have these comorbidities? What is the training that we all need when we're working with people with dementia? And I think part of my hope is that we don't spend all our time focusing on the nature of the association, but we remember that there are real people at the end of this, and there's other things that we can be doing to help them. Thank you very much. Liz, you may let me know, do you want me to leave the slides up, or would you like me to stop sharing them?
I don't mind. If there's anything specific people would like to ask about as part of the presentation, it might be useful to have them so you can refer back to a specific slide.
Okay, I'll leave it open just now then.
Thank you. Thank you very much for your presentation as well. Hopefully everybody found that as useful as we did. I've heard it a couple of times now, and it's still there's always things to take from it, I think. So I don't know if anybody does have any questions. If you want to put them into the chat, You've got some clapping hands there, so there's some appreciation coming up at the bottom of the screen. Thank you, Kevin. Yeah, anyone with any questions at all, you can raise a hand or put it into the chat and we'll go through those.
I'm sorry, there seems to be a number of people had difficulty joining us. I've no idea. Someone might just explain to me what the issue was, so I know if it's something to do with my end, or just in case this ever happens again.
Yeah, and no, I don't think it was your end at all. I can't say what it was, unfortunately. My technical knowledge does not go that far. However, they are both Victoria and Claire have made it in now. So yeah, I'm afraid I don't know what caused the issue because it was set to just let people in, but we were able to resolve it in the end, so that's good. We have had Paul Hope has asked a question in the chat here for you, Kevin, who said thank you. And as an overall message, being a risk factor is more about correlation and not necessarily about causation, which I assume you can see to read there and see.
Yes, yeah. Thank you, Paul. Actually, Paul was one of the people that had difficulty at the beginning, so it seems like he's got it all working, so that's good news.
Good.
Yes, Paul, that is one of the take-home messages, that there is an association, there is a link there. We don't deny that, but it's understanding the nature of the link. You know, let's say it was a common cause, vascular changes in the brain. If all of these things are going to happen, that would be unfortunate. But importantly, for your point of view and mine, as a hearing professional, it means that providing a hearing aid isn't going to be able to undo these common causes. Whereas, you know, if it turns out that hearing loss is primarily the cause that's driving it, then avoiding hearing loss or doing something early would clearly be a good thing and might reduce the risk. So yes, that is one of the take-home messages, Paul. I might just ask Claire and Victoria, because I don't know how much they've missed of it. I'm sorry about that. But if either of them wanted to make any comment about the statement about why BIHIMA was so keen to get involved early on, and how we worked together hard to put together this document. Any particular comments from either of you? Or did Siobhan make it from BSA, by the way? We weren't sure if Siobhan had a problem or not. But anyway, anyone, or BSHAA, sorry, I don't want to miss anyone. Do any of the bodies or learning societies want to make any comments, that something that I might have missed? Or
so Siobhan, I cannot see that Siobhan's been able to join us today, unfortunately. But I'm just enabling the microphones for Lynn and Claire so that if they want to jump in, they can do.
does the silence mean you don't have anything to say? I don't want to put you on the spot.
It won't necessarily be that. It may be. It's still muted. Bear with me, Claire.
Oh.
Sorry.
Does it take a lot to keep Claire muted?
We have got a question from Dee in the chat while I just figure that out with Claire's.
Okay, let me just read it.
There
what is the best way? Yeah. No. Yeah, sorry, I've just been distracted by Victoria. What's the best way to address family carers not helping patients using aids? Because what the point, they have dementia, I can't. Oh. Well, that's a really important point, isn't it? I mean, you might argue people with dementia are even in greater need for looking after their senses, their ears and their eyes. And I don't have a quick answer to that, Dee, but I'm pretty sure in the James Lind Alliance priority setting partnership, when stakeholders had to identify what are the most important questions to them, that's most likely to be a question that was a priority. And that will put it on the national agenda. When people are going to be carrying out research, they'll be able to say, look, this is of national importance. And that means they're potentially more likely to get funding for it as well. So I think it's a very important point, and it is something that we need to address. And you may argue that if someone's going to a memory clinic with potentially mild cognitive impairment or dementia, because it is associated with senses, the ears and eyes should always be tested anyway, and something done at that stage. So a good question, and I think watch this space. Hopefully there are going to be work done to give guidance on that exact point. Oh, hey, Emma, is this Emma Mackenzie from Southampton? Should we be pushing for adult hearing screening or targeted adult hearing screening? Wow, so these are good questions. The National Screening Committee will not support an adult hearing screen because they say there are too many questions that are unanswered. For example, what age should we introduce an adult hearing screen? And what should be the nature of the screening test. And let's say we decide, okay, at age 45 or 50, we're going to have a screen, and we've decided, and it's going to be a speech and noise task. The next question would be, so are people that age likely to want to adopt the intervention that's provided if it's hearing aids? So because there are so many unanswered questions right now, the National Screening Committee won't recommend this. I think that probably is the right decision. We've been doing some work in Manchester for some time, trying to provide answers to these sorts of questions. If it's more, should there be screening done on people with dementia? I guess I have reservations that people in audiology, is it their role to be screening for cognitive decline, or do they have good contacts lined up? It's not something that would be necessarily high up my priority area, but I do think outside our own area, if there are people with health conditions like dementia or at high risk or mild cognitive impairment where a high number will have dementia, then clearly we should be doing everything we can to support these people and keep them connected and engaged with everyone else. And that's where there might be an argument for doing it. Hope that answers your question, Emma. And I can see Claire.
Yeah, Claire's there with her hand up. So we'll welcome you in for a moment.
Morning, Kevin. Sorry for my rather tardy appearance.
Not your fault.
So going back to your comment of why we thought it was important to do, I'm not sure if you mentioned in your first 13 slides that it came up at the World Congress of Audiology last year in Paris when we were all sat there listening to several streams about cognition. But in one of the keynotes, someone not from our country highlighted some advertising on a storefront that had a very direct link of, paraphrasing slightly, come and get your hearing aids, will save you from dementia. It was that bold a statement, and basically she pointed out how wrong this was and how appalling this was, and all of us from the UK sat there and kind of shrank a little bit because she literally named and shamed the UK as having poor practice about utilising dementia and the risk of it as a sales technique. So it was just one part of one talk, but everyone else in that cognition stream then kept referring back to it. So it obviously hit home with a number of people at the Congress. So when we came back, Victoria kind of posed that to a number of people about whether we should do something and have some statement about it to ensure that basically the UK aren't named and shamed again on a world forum. And this document actually was a really good bit of collaboration that actually did happen very quickly, which we're not noted for either when various professional bodies get together. So we felt as BAA it was really important to make sure that patients were getting the right message. We'd had anecdotal reports from audiologists where they'd seen patients who had been really upset, or family members who'd been really upset, where the dementia focus in their options about aiding from lots of different sectors, not just one, had been pushed really hard, and they'd found it really difficult and very uncomfortable. So we just felt it was time to kind of have a bit of a level playing field, have it explained in a way that we all understand. So we're not making false statements or putting undue pressure or distress onto any person with hearing loss looking for aids.
Yeah, thank you for joining us, Claire, and thanks for clearly outlining one of the issues that we spotted at the World Congress of Audiology last year. I mean, what we have to be careful of is we mustn't just bury our head in the sand, right? But this is difficult. It is difficult for such an emotive thing as dementia, saying when there's so many uncertainties, how do we get it across? So what we've tried to do in this position statement is to steer a path where we're not avoiding it, but we're not giving misleading information. But, as I said and I think you're still seeing it the final slide, I think it does provoke wider discussions. This partly, I guess, also goes back to questions about screening, about what are the behavioural, the health behaviour motivators. And I think we haven't been particularly good at that. I would like to see a position where there are good quality online hearing tests supported by the NHS, and people are happy at home to do an online hearing test. And people from a young age, my teenage sons, for them to take an interest in their hearing as well as other aspects of their health and well-being, so that they're being proactive, and there's a shift from being reactive in treating things to being proactive and trying to prevent. If we can get to the stage that there are good quality online tests, someone could be watching television, the adverts come on in between Coronation Street, instead of making a cup of tea, they put the sound off of the adverts and they test their hearing. That would be a great outcome. I think there are potential opportunities for the NHS to be involved with some of the newest innovations in terms of technology, and a proportion of the public who would be quite happy to deal with hearing aids on their own, or at least know there are people there to support them. Not everyone, absolutely not, but that support would have to be there. So I think there are opportunities of using what is a rather difficult current position we find ourselves in to change things for the future. And I'm just looking at Emma's question, sorry, Amy, I beg your pardon, and I think it might be similar to Emma's one, and I don't have an answer for it, but I do think if someone has something like dementia, where they're going to become socially isolated, the more we do to support these people, the better. And we have to become more confident at doing it. And I hope some of the research that people now take up, perhaps on the back of the James Lind Alliance's priority questions that hopefully we're all going to see in the not too distant future, that will help address some of these important points that you guys are asking me today.
Thank you, Kevin. Lynn Wetherill, I didn't know if you wanted to say a few words about why it was that BIHIMA chose to get involved with the statement, just to add to what Claire's already shared with us.
Thank you and hello. I think it really is important for those of us that work within, as we call the private sector, that we also are on board with this and have a greater understanding of this, because I know that there is a tendency, and without naming and shaming, that there are those that will use this as a tool to almost create a sense of fear and a sense of worry for people, that they will then purchase hearing aids to sort of combat that fear. And I myself, as a practitioner, have seen it, that family members have come in, and perhaps mum and dad are later in years, and they themselves are in homes and in care facilities because they have dementia. And the greatest fear for that daughter, son, is that they themselves will develop it. So they want to be proactive, and they want to get hearing aids because they want to combat it. And I think it is really important that as clinicians, we are ensuring that our information is correct, that we can guide those and support those people in ensuring that they get right counsel, right support, and in no way feel pressurized to do something because it's misinformation and it's something that they've read in the Daily Mail or Daily Express and have created this fear themselves, and suddenly they're at my door panicking. And I think that's important for those that work within the private sector, that we have the right information and the right tools to support those people, as well as those that come in with us that are support for family members who have dementia.
Lynn, thank you very much for these important comments. It just prompts me to make the comment that when we prepared the document, we weren't wagging our fingers at any particular group. In fact, if we started to kind of cast blame, I think we wouldn't have the desired effect and the impact of the document. So we've kind of started with a level playing field to say, what do we do to just help us all be a bit clearer on this very complicated and challenging topic? So thank you for what you said. I've just put this slide up because I wanted to counter what you said by, it's not just misunderstanding in private practice. Here's a poster that was up in the waiting room of one of the audiology clinics in the Northwest. And there was a middle-aged woman, actually probably younger than that, waiting to be seen. She has a hearing loss. This was in December. And while she was waiting, she was standing reading this poster. And I should say, there's aspects of the content of this poster that I think is correct, but some of the information on the left-hand side saying there's a risk and it's untreated hearing loss leads you to believe, okay, well, if I treat it, it'll go away. But this woman said to an audiology colleague, oh my goodness, I didn't know my hearing loss is going to cause dementia. Why did my doctor not tell me this? Please, is there someone here today that I can speak with? That's the sort of unintended consequence if we just don't have the right words. So it applies to all of us. We're not blaming anyone. We're just trying to help everyone understand it and have a clearer view. The document is for guidance. As registered healthcare professionals, we have to be able to defend and justify what we do. So everyone has to be able to do that. And this document is just there to guide and to help and support. And if someone has a different view, then they have to be prepared to defend their own view. But thanks for your comment, Lynn.
Thank you. And something I should also mention is, so when we send the email around after the webinar and share the recording of it, we will also include a link in there to the joint position statement. So if anybody's not had opportunity to read it in full or they want to digest it again, then there'll be easy access to that as well.
And also, Liz, if you don't mind, if anyone has any particular comments that they'd like to draw our attention to, parts that they think are particularly strong, or suggestions of things that could be omitted or might be included, or revised wording, please be sure to share it with us, because we're doing this on behalf of everyone, and we really want to get it right or as best we can.
Yeah, absolutely. And then any comments we can feed back to the team and developed it into Kevin. So I was about to ask if there's any other questions, and there's a long one that Peter has just popped in there. I'm sure you can read it yourself, Kevin, but I will just quickly read it through. So you're talking directly to the audiology profession and industry, but your research and observations are frequently mediated by the science reporters in the media. You have mentioned how, despite explaining yourself well enough, the outcome can bring some head-scratching translations of explanations, which can be to the inverse of what you're trying to say. So how much of the blame for imprecise understandings of the dementia/hearing loss question can be attributed to poor science and health reporting, not just misinformation, but mischief, disinformation and malinformation, such as the hunt for clickbait, etc. And I guess this links to the example that you put up earlier of the story after your radio interview, and how seeing a journal, taking some key points and then putting it into a media story can lead to confusion. Do you think that there's anything that we should do as a health industry to combat this media problem?
Thanks for your succinct question there, Peter. So I don't know if you were present for the whole presentation, but I gave an example of an article that came out earlier this week that I was interviewed for, nothing to do with dementia, but then the headline was about dementia. I think, I'm not sure there's a simple or a quick answer to this. And it's also a bit like saying, if the horse has bolted, are we in a position that we can reverse things? And I think there are some people who doubt that we're able to do it, but that didn't prevent us from attempting it by having this guidance article, and we keep pushing. I for example, have met with BIHIMA to discuss it, to make sure I understood where we're coming from. I met with the European Hearing Instrument Manufacturers Association, and I've met with one or two individual industries. I'm also sharing it like we are with our health professionals right now. I think there can be an element of clickbait, but I just caution that against the article that appeared this week, that when it looked like it could be clickbait to get a quick headline, it turns out it was the way the articles and press releases had come out. So even at that level, there's pressure on people like me when we're doing research, that our employers wanted to have impact, encourage interacting with the press. There was a time when I didn't really interact too much with the press, because there was always a fear, I better be so careful what I say, but then I end up looking stupid because I'm not saying anything, or you get misquoted. I've come to realise that actually you can't just wash your hand of it. You have to play the game and help to do your best. So I do it a lot more now. You can imagine how surprised I was to see the newspaper article, which rather gave a complete opposite view of my current one. I've spoken to some people within NHS England. I've alerted some people within the Department of Health and Social Care about this. So I don't know if we're going to be able to put the genie completely back in the bag, but I'm up for doing what I can to help us as organisations and healthcare professionals to do what we can. Because at the end of the day, it's individual patients who are seeing this sort of stuff. Just because you make the link, hearing loss might cause dementia, it may have the complete opposite effect, and it might drive people away from addressing their hearing loss because of negative messaging. And we know that this happens with negative messaging. Even if it doesn't drive them away, it increases anxiety and all the things that we associate with raised blood pressure and things. So it's a very important question, Peter. I think you know the answer is as much as I do. So we're doing our best. Sometimes it's clickbait. Sometimes it's because we're not good with press releases or how we sell our findings. Everyone who's completed a research study wants to make it think, this is the best research study I've ever done. I want to share it. And then we step back over time, and sometimes what we do is modified. I include myself in that, but I think we should collectively be doing things to try and help. And actually, thank you for the stuff that you've published in your article to help as well.
Just to add to that, I think you're absolutely right. There are lots of occasions where things have been misinterpreted in the media, and particularly mainstream media. So outlets where they are often dealing with these type of issues and talking about the industry and the profession, they'll have much more knowledge and understanding. But if it's a journalist who hasn't often written about this type of subject, they won't have the background understanding and will need more explanation. I would suggest, if you have the time and the will, to go back to that the person who wrote that article and just explain where their correction would be, because it may be that they do a correction, as was in the Lancet example that you gave, or it just helps them if they go back and cover this in the future, that they understand it a bit better. But having, I think, ongoing discussions with members of the media is the way that we educate and raise awareness, in the same way that we do with the general public, I think. But it's a difficult and ongoing challenge, I would suggest.
So I can add a PS to that story, Liz. I contacted the journalist earlier this week on where is it, Thursday? On Tuesday, to say thank you. I'd seen the article. I was surprised about the emphasis, and then I explained some of the points that we were discussing today, and she was very generous and kind, and rang me yesterday, and we spent about an hour chatting about the topic yesterday. And really, some of the key messages that were misunderstood was hearing loss is a risk. People and journalists tend to assume risk means it's going to cause it. So I was explaining, maybe don't use the word dementia and risk, talk about cognitive decline and association, and we don't really understand the nature, and maybe one causes the other, we just don't know yet, and how you might phrase it. She told me she's making it her campaign to try and raise the profile of hearing loss. Her last campaign was on preeclampsia, and she's up for some medical journalist award, and that she wants to find ways of encouraging people to look after their hearing and have hearing tests. So I'll be watching carefully for other articles that come out. But yes, as you might gather, I didn't let that one go unnoticed.
Good. Well, that's a positive outcome, I think, as well.
Yes.
We have had another question just come in whilst we've been discussing that one. Will we ever see randomized controlled studies, and who would fund them, and how long will they take?
Yes. So yes. So you're right. We assume that the randomized ones are the best. So the more we have, we can look at the overall pattern and see what's happening. There has been a fantastic randomized control trial on this very topic, but just the one, the Achieve study from USA. Absolutely fantastic. Lots of great things have come out of that trial. And actually, I wish I'd been associated with it. So it's not just about, although the primary outcome was to do with cognitive decline, all the secondary measures showing the benefit of using hearing aids. That study, the primary outcome was, if you take people, some get hearing aids, some don't, people with hearing loss, I should say, and then you look at their cognitive decline over 3 years, the primary outcome was that there was no difference between these two groups after 3 years. There was a secondary analysis that said, actually, if you take the people who have health conditions that make them a higher risk for dementia, these people seem to have slower decline, but the effect size was relatively small, and it is only one study, so we're just watching that with interest right now. Will other people fund it? I hope so, but I wonder if this has to be embedded in a larger trial that's not just focused on hearing, but in other aspects of health, where people can be tracked over time, because they're big studies and they are expensive studies. I do hold out hope that there are alternative methodologies. And one of my earlier slides, I mentioned the genetic one, the Mendelian randomization, that there are studies like that which will help us identify the nature of the relationship and the cause. So there has been an RCT. It didn't show an effect after 3 years in the general public. potentially a small effect in a subgroup of the population, but let's wait and see on that. Hopefully others will do similar work, and hopefully other types of designs like the Mendelian one will help answer the question. Although I should say, what if we can never answer the question? Because life can be a bit complicated at times, right? We still need to be able to be prepared to know how are we going to explain this to individuals. So it may be the sort of things we've been discussing today we're going to be using for considerably longer, because I don't think we should just bury our head in the sand, but we absolutely should think of you know, a wider focus on how we help change people's behaviour so they become more proactive instead of reactive.
Thank you. We do still have a few more minutes if anybody has any final questions to add in, but I just wanted to take the opportunity while we're still here to say thank you. I'm afraid I didn't introduce myself at the beginning. My name is Liz Pusey and I work as a communications consultant with BIHIMA. It's been wonderful to see so many people join us today for part of this discussion. I think it just proves, as you said before, the interest that there is, continued interest. So thank you. And it's been really good to have representation also from some of the other professional bodies here with Claire and Lynn and others. So thank you very much for joining us. And as I mentioned earlier, there will be an email afterwards that we'll send out with a recording of this for people to read back, watch back. And we'll also share a link to the joint positioning statement. And if anyone wants to send any questions in, then we will share them with Kevin and the team. But thank you very much for joining us all today. And if there are any further questions, we'll leave it there. Thank you very much, Kevin.
Thank you, Liz. Thank you, Paul. And thank you to everyone. It's quite a big number, and that's quite heartening to see. I hope some of this has been useful. Yeah. I am, if you don't mind, I'm going to run. I've got to get to the railway station to catch a train, so I need to get my bag and run out now. But if anyone's got questions that we haven't answered, just drop me an email and I'll do my best. Thank you. Bye-bye.
Thank you so much. Thank you, everybody.